Right. Okay, for today's agenda, we're going to be looking at diagnosis coding. Do any one of you know what's the diagnosis code?
ICD-10.
Yes. ICD-10 diagnosis coding. So ICD-10 is they are the ones that develop the diagnosis codes. And diagnosis code varies, and we're going to look at that as well. So the importance of medical necessity. Most payers, when they're paying a procedure or a service, they want to see that a medical necessity is established. So you, your resident, but the physician would say, but I've established medical necessity, why don't I get paid? But the payers and Medicare have their own black book as to what they deem to be medically necessary and what will allow a procedure or service to be paid. And we have CPT codes and documentation requirements. CPT codes are used to report your services and your procedure, mainly in office or clinic setting. In an inpatient setting, the facility uses the ICD-10 PCS, and the providers will still use the CPT. But for us, facility coding, we're looking at CPT coding for facility and office visits. Now, Dr. Lam also said, can we look at the CPT codes for thyroid ultrasound, biopsies, and the glucose monitoring? So I have them there because that was at his request. So one of the questions he had in his email is how diagnosis code used in coding, in the coding process. And I said to him, normally physicians, you're writing like the patient has diabetes. They just write what is diabetes. But when it comes to coding, it's breaking down and so in such a definitive way, like you have diabetes, is it type 1, type 2, is it controlled, uncontrolled, and you gotta be as specific as it gets for the payers to understand and see what condition you're treating the patient with. So I have here diagnosis codes are used as part of the clinical coding process to identify your disease, your disorders, your signs, your symptoms, abnormal clinical lab findings, screening, etc. So whatever the patient has or whatever is being treated or whatever is considered questionable, we have a diagnosis code for it. Got it? Now, look how many ICD-10 diagnosis codes are there. Close to 70,000. So for you to be chosen a code, it said these codes are 7 to 10 characters in length. The first digit is alpha, the second digit is, and third is numerical, and it goes on based on that. And here's an example of a diagnosis code, Z 13.29, encounter for screening for other suspected endocrine disease. Now here's the thing, if provider chooses a diagnosis code, say Z13, and submitted it, it would be considered truncated, invalid, and the claim will be denied. And why is that so? Because we have to report the code based on the most specific it is. So the fact that there is 2 additional digits that can be reported to divide the code, you got to go to as specific as the code gets. So you could not have Z13 and that's it. You got to go Z13.2, and if there's additional digit as the 9, you would have to do Z13.29. Is that clear? Sure? No questions so far? Okay. And what I just said is in the the last 3 bullets. So here we have, again, medical necessity. Diagnosis codes are reported to establish the medical necessity for procedure or service. And what the documentation should entail when you're writing your notes or working with your attending, what the documentation and what we're looking for as auditors on the back end. What is it that I would say, okay, the provider has established medical necessity, and so we are gonna appeal if the claim is denied. What is it that gives us the meat on the bone to justify the service and to fight for the payment? The severity of the signs and symptoms or direct diagnosis exhibited by the patient. It was that documented. Second bullet you could read. The third, the need and availability of a diagnostic study and/or therapeutic interventions to evaluate and investigate the patient's presenting problem or current, acute, or chronic medical condition. So when you're seeing the patient, what the patient has, does the patient have any other chronic condition that you're treating at the time that you have addressed? All that needs to be documented, and so I can say, okay, the patient came in for thyroid, but this patient is also diabetic, uncontrolled, all these things were captured and treated, and so that's gonna establish your medical necessity for whatever procedure you're doing. Michael, you want to add anything? Have you heard of CMS and Medicare? Okay. So here, this is what Medicare's definition of what's considered medical necessity. Medicare is saying no Medicare payment shall be made for items or services that are not reasonable and necessary for diagnosis or treatment of illness or injury, or to improve the functioning or malformed body member. So if you're not establishing this, Medicare will not pay, bottom line. Doesn't matter what service was rendered. On the back end, we see so many procedures and services and studies. Your ultrasound, your duplex scan, you name it, it's being denied because Medicare is saying, yes, you did it. I have some that's going on now with, is it head and neck, I think, and what they're doing, they're harvesting soft tissue from one site and put it to another for lymph nodes. Patient have lymph nodes and they remove it, and now they want to know if the tissue is healthy from one side to the other, and they're doing a lot of MRAs because they want to see if the vessels are fitting. But medical necessity not established, and so Medicare is denying, thousands of dollars just being denied, not going anywhere, because Medicare has their own black book as to say, these are the only covered indication that we deemed medically necessary to do the study. So. Well, rule out is funny because on the outpatient side, ruled out is not a confirmed diagnosis. On an outpatient setting, for rule out, what you need to code is the signs and symptoms the patient is exhibiting at the time when the patient comes in. On the inpatient side, because you've done the workup for related to the rule out, then you can bill for the condition you rule out. There are some exceptions like HIV and some exceptions that you can't. But most of the cases, if you've done the workup for the diagnosis, you can bill. But on the outpatient setting or clinic office setting, report the signs and symptoms that the patient is exhibiting at the time that you're doing the study. Michael, anything? So here's again, So a service might be medical necessary in your diagnosis or physician eye, but it does not make it a covered service based on Medicare requirement. So it is advisable that you look at the LCD, which is your local coverage determination, or your NCDs to see if these diagnoses are covered. And I actually put a database here, so let's see if we can access it. Hold on. Can we have Google? I want to just bring up one LCD so we can see what is an LCD. Mike, what's the CPT for ultrasound duplex scan? You do it 95971? 95. Let's see. Hold on. Let me see if I can get into my coding system. So I want a code. Sorry, can't see. I think it's 9.971. No. trying to find one of these that I know is. So this is the LCD. And we're just going to look at what Medicare would deem covered indications for these. So here are the covered indications that Medicare has listed here. So if you should be doing any of these studies that's listed here, and it's not listed among the diagnosis code that Medicare has here, it will be denied, bottom line. And there's no way around it. So this is just an example. Here are the different codes for different studies, but Medicare is saying if you should consider doing one of these studies, you must have one of these indications. There's no exception to the rule, it will be denied. So they have their own indication as to what they consider covered services. So outside of Medicare, like we're looking at maybe now Blue Cross, Aetna, these are examples of some of the third parties in what the language they include in their medical necessity policies. And I am not going to read because we all could read, but I could like skip one or two bullets. The treatment must be consistent with the symptoms or diagnosis of an illness, injury, or symptoms under review by the provider of care. Because if the treatment, most time what you're looking at is a treatment with something that is deemed cosmetic. So it's like, oh, all these wording, what are we saying? What the insurance company is saying, if you're treating the patient, or if you're doing a procedure on the patient, you must establish medical necessity. You're not doing it because your friend has a scar or mold on her face and she doesn't like it and she can come in and get it. I know you're not cosmetic driven, but that's just an example. So you must establish medical necessity because oftentimes they'll request the documentation for review. You first submit your claim in the forms of code. So you have your diagnosis codes, which are your ICD-10 codes, and you have your CPT codes, which that defines the procedure. It's submitted to the payers. The payers of edit system. Like what I do on the back end, I create a lot of edits on the back end because what we're trying to do is to protect Mount Sinai from being audited. So everything that you could think of, a pacemaker, I need to see my device, I see a pathology, I need to say excision or biopsy, all of that is taking place in the back end. And that's what my department is there for. We are the charge master. Basically, we are the traffic cop. I see this, I don't see that, I need to put it together. Reach out to the department, why am I seeing that you need a thyroid biopsy, but I don't see pathology? You did an aspiration, but I don't see any cytology report or whatever. But I am putting that all on the back end to make sure when the claims go out, clean claim go out. So, but this is what the payer is saying now. Treatment is furnished primarily for the convenience. Treatment is not, I should say, not furnished primarily for the convenience of the patient, the attending physician or another physician or supplier. And that is big on pharmacies and your friend with the pharmaceutical company and you're giving patients all they shouldn't get because you're getting an incentive on what's new. So these are all things that are being looked into by third party and Medicare themselves. Any questions so far? Am I that good or is that boring? Okay, so now we are through with diagnosis and medical. Sure.
That last point.
Yeah.
I just want to try to understand that.
Disbursement of medical and/or treatment must not be related to the patient or the third party monetary status. So you're not doing it because Mr. walk in and you're doing it for that reason. Make sense? You're not being influenced to do a procedure, but it's not medically necessary. because you can't say no to Mr. Got it? Sure? Okay, so now we're through with diagnosis and medical necessity. Is there any question on diagnosis and medical necessity? We're supposed to code a procedure. If you did 4 or 5 procedures and you're going to report it on a HICA form, would you make sure that you've established medical necessity for each procedure that you perform? Clear on that?
When we're documenting it in our note, and
Yes.
also we look at the diagnosis code from the encounter as an option.
Where you get the diagnosis code?
So it's just there's, like, when we're putting in orders, we can search
A
diagnosis.
preference list?
Yeah,
Or, okay, so it's an EPIC and a preference list.
it's epic. not-
Yeah, it's EPIC. I work with EPIC as well. So when they build in, they send it to me, I work with them and provide them with the diagnosis code and stuff like that. Larry, Dennis, Winter, all of them, we work with them together. It's just back-end work to make the flow on the front end for you guys. So when you're saying, when you're documenting, that's one, and you choose a diagnosis, that's the other. But oftentimes, you could choose a diagnosis and you could say, okay, patient has diabetes, and you go ahead and you choose diagnosis, diabetes type 2 uncontrolled, but your documentation is just say diabetes here. So you can choose it, but it becomes questionable on the back end.
Okay, so there has to be, it has to be both from the note and. the
Yes,
diagnosis.
yes, exactly.
Code the diagnosis, code should match the documentation.
Bottom line.
Is the day affected, for example, in the clinic, we could type diabetes
Mhm.
and then an association of.
Manifestation?
The manifestation is hypertension, but at the same time, this patient, has neuropathy or like retinopathy, like all these other complications. I know like my previous jobs, we would list them all because we get paid based on how many complications this patient has. In this case, we just put one diagnosis.
No, you list all the diagnoses that you've seen the patient for and you're treating the patient for. From the diagnosis, medical necessity will be established. So while I'm telling you to establish medical necessity for a procedure, if you see the patient and you address and treat all the condition that you have addressed and treated, you can report it.
So you report all that.
Yes.
How, for Medicaid patients, on Medicaid, how is the reimbursement?
For that, Michael, we're going to speak on that the next presentation, but for Medicaid patients, your E&M level are driven primarily by the complexity of your diagnosis, APG. So it's driven by the complexity of your diagnosis. So yes, you should be reporting that, remember, but that's the office visit, which is totally, somewhat different from your procedures. So what I did was today, I divided the presentation. So today we're looking at procedure and services and diagnosis. And the next presentation, we're going to be looking at office visit and from the office, the diagnosis and how the diagnosis is tied into office visit to bring you to a certain level. Okay, sure. Okay. So what he wanted to know, Dr. Lam, one of the thing is, what's the procedure code for thyroid biopsy? And I figured since he asked the question, what's the procedure code for thyroid biopsy? I'm like, okay, let me also give them the aspiration and the injection for thyroid cyst. And let me also make the distinction that your guidance is totally different from if you're doing an ultrasound of the thyroid. Got it? So if you're doing the guidance or fluorescent guidance or MRI guidance, these are the CPT codes that you will use in addition to your biopsy, thyroid biopsy for the guidance of the needle. But if the patient, if you're placing an order, because I know you don't do an ultrasound of the thyroid, but you might eventually at some point place an order for thyroid ultrasound, this is the code you would want to look for at the very bottom. That's there?
So if we're doing FNA.
FNA is coming.
Biopsy, we code all three.
Okay, so the FNA is coming on the next slide because what the FNA codes do, it also includes the modality that's used. So, right, yeah. The new, it's a recently updated CPT. So. But in this case, if you're doing your thyroid biopsy, this is the code you use, aspiration of the thyroid cyst or an injection in the thyroid cyst, this is what you use. If you place in an order for your ultrasound of the thyroid, that's what you use, and these are your guidances.
So we don't report needles, so essentially we would be doing something from the second column and the third, and then what are FNA
Now, FNAs, you don't report the guidance separately because the code itself includes the guidance. So if you
do report ultrasound.
which of the ultrasound? The ultrasound of the thyroid, yes, yes. If you place the order, because I'm assuming you're sending the patient to radiology, right?
No, we do not.
You do them yourself? Okay, so then that's the code. If you're doing the ultrasound of the thyroid, that's the code. So these are your FNAs. And there are two distinctions that we should know for FNAs, and that's one, what modality was used, and if you're the first lesion or subsequent lesions, what are the codes we use? And last but not least, is it with guidance or without guidance? Because the last bullet is telling you if you didn't use any guidance at all, this is the code you default to. And I'm assuming these codes are in Epic as well, right? So once you place the order, it's complete. Okay.
They are,
It's hard to know what, yeah, to type it.
What to type in?
Yeah, but usually we're just doing one.
So you just do it FNAs, and then from FNAs you should see, I don't know if you guys have a preference list, but from FNAs you should type in FNAs, you should have these options, and based on what modality you use, you should be able to make your choice. Okay with this slide? Why I feel like I'm going so fast? Oh my God. So this is also one of the topics that it wanted me to cover with you guys, and that's your continuous glucose monitoring. Are you currently doing this now? Not on a regular basis. And if you do you have an understanding of what you choose and what you don't? I need to work with Larry. I don't know if you guys know Larry Yu. He's, and Denise Winter. Because in choosing glucose monitoring and from a facility setting, if it is the ambulatory owns the equipment that's used, what happened is the physician should report 95251. But the technical charge, have you heard of physician charge and technical charge? How a charge is split? Okay, I know. But there's some cases where I don't know if you guys are Article 28, so I don't even want to take it. Oh, good. So bingo. Because I didn't want to go there with it if I'm not sure.
Everybody, at least at
Okay. So what happened if you're doing glucose monitoring? What happened is the charge is split. The physician is going to report theirs on the HIC for 1500, and you have the UB for the hospital side. So when you're doing it, it splits. The hospital, because we are billing the technical portion of it, so if you notice what it says there, provide equipment, sensor placement, hookup, calibration of monitor, patient training, removal of sensor, and printout of recording, that's actually reported on the technical claim. The physician should be doing the interpretation. Because there's a tech or someone who's doing all this hookup and stuff. It's not the physician per se that's sitting, oh, I'm going to put this sensor, I'm going to put this. No, right? So that's what happens. So what Medicare has is what's called an addendum B, and you can go there and it shows you what is for the hospital and what is for the physician. If you should, as a hospital, report 95251, it will be denied as non-covered, because that should be the physician who is reporting that. The physician is doing the interpretation and report. The hospital is doing the hookup. So although you're seeing two codes there for the one that's not patient-provided equipment, because 95249 is when the patient provides equipment. So these two the two first bullet relates to if it's the hospital that's providing the sensor. So, and in this case, you have these two codes, but you're not reporting these two codes. It's gonna split. The hospital charge will split, and so this is where we need Epic to work with us and the back end and said, when the physician ordered glucose monitoring, we should have split billing where it defaults. So you just order it, but behind the scene, it should split. One code should go for the physician side, physician charge, and another code should go for the technical charge. Type 1, physician, because you're doing the interpretation, physician doing the interpretation. And the other one where you have some tech or someone working to do place the sensor and the hookup of the hospital will report 95250. Let me just give you, can you go back to Google here again? Can you help me to go?
Oh, yes.
Yeah. I just
You
want
wanna
to
go back?
show you,
Which one
no,
do you
not
wanna
to
go
the presentation, I want to go back to Google. I want to just show them quickly what an addendum B looks like.
If you go to Safari.
Oh, where am I? Let's see if we go here and then go here. Okay. And this is all finance related, but it's good when you have some person knowledge of what's going on the back end. That's the most updated. It ended up being. Open file won't be visible. Okay, yeah. What was the code again, you remember?
Which one?
Okay, 95250. That's what it is? 95250? That was it?
Yeah, 95250.
Okay. Okay, do you see how, this is on the back end, so you see how it splits? And you see there's no reimbursement for the 5-1? We are looking at the hospital chart here, what Medicare said I will pay for. It's not like Medicare is saying I won't pay for a status B and there's no reimbursement, but because it's physician, that's why there's no reimbursement there. This is only for technical, what technical will get reimbursed for. So the 5-1, there's no reimbursement there because it should be reported by a physician. So if you should go to Medicare physician fee schedule, you'll see a payment for that one, but for the physician. So this is just all technical based driven, but hospital based driven here. Does that make any sense? Sure? Okay. Well, and the truth is, you should not be determined, oh, what code should I bill, what should I not? It's Epic should have it for you guys. So once you order that glucose monitor, behind the scenes, it splits. What goes for professional billing, what goes for technical billing.
Yeah, I think there's two current codes. One was for, like the clinics, and one is for, like, that's not.
Yeah.
Yeah, I want to look, but for when this is a patient provided equipment, let's look at this code, 95249. See, there's a reimbursement there. And what this means, when the patient owns the equipment, both the provider and the facility can report the service. But what happens now is, on the back end, and I don't want to get too complex, but we have modifiers that make the distinction. So the physician claim will take a modifier 26, and a hospital claim will take a modifier TC. And that's what made the distinction on the back end. For when the patient holds the equipment.
So do you guys, like, how does this work? Do you, every note we write is reviewed by a coder?
Well, we are certified coders. So there's a difference between a certified coder and a biller, because the things that a coder knew, a biller don't do it, and sometimes the things that the biller knows, the coder don't.
So every note is reviewed by a coder?
It's a possibility, but no. It all depends on based on edit system, or if my boss has sent me and said, I need you to go do a retroactive bill audit on endocrine. I want to see all the thyroid biopsy that's going on. I want to see all the FNAs are going on. I want to see if they're capturing all the different lesions. I need to know if I'm maximizing my money. And at the same time, I need to know if you're at risk for an audit because you're overbilling. Because you pulled one lesion 6 times and you think you should bill for it 6 times, it's still one lesion. So, so it depends on what I'm looking at when I come to the audit. So only based on edits that's set on the back end, chances are your claim might hit the back end for review. Like I said, I see cytology, but I don't see an FNA. I see biopsy, but I don't have a pathology report, a pathology charge. It depends. I am seeing that you're saying you're doing a thyroid biopsy, but I don't see medical necessity established while you're doing it. So
Most of this is usually done like
retrospectively, yeah. Randomly, blah, 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 okay. But you can be on a full-blown review. And it's our job on the back end, and Michael is here at front end to work with the clinics, because we're trying to maximize reimbursement and at the same time keep the institution audit proof. I've gone where you have the different subject, but you have the right heart cath with your the heart biopsy, and the OIG came big at us, and all my justification could not override some of the things that they still ding us. We play by millions. So that's why I'm there. When I see right eye biopsy with whatever thing, stop, send back, take it off. There's no justification. So that's why we're there. Okay.
I have a note here, so 95250, is when you do a professional interpretation once a month.
5-1 is professional. Where would you get 5? But like I said, you're not supposed to be struggling with codes. You're supposed to be able to place your order, and from your order, your code's supposed to be on the back end. But if you go to your preference list, and once you're doing a glucose monitoring, if you're going to choose for professional billing, you should be seeing the interpretation.
But there's 2 types. There's one that the interpretation of the patient that owns the sensor and we interpret it once a month.
Yeah, that's the format. Patient-owned equipment.
That one is which code is that?
CF.
That back to 49.
Yeah. Mhm. And that's what's also on the front one. Patient provided equipment. That's it. It was on. I made sure I underlined it right here. Like.
I have the first time insertion. When you first insert and then you can't build for it when you first insert and they come back again after 7 jobs, then you build for
Why would you?
195,249. And then to interpret, you do 195,250. And then when you do a Libre, a professional one, there's a different code. So I'm confused. Because there's ones that, right, like the professional Libre that we keep for, give to the patient for 2 weeks and we
Who owns it?
the hospital.
Okay.
Which is,
50. Okay, 250.
okay. Got it.
That's why I took you to addendum B, because it's listed right there.
So,
Okay.
saying something with the CGM, we're interpreting their data from their town. Building. 95251.
If it's hospital-only equipment.
It's hospital.
These two goes together. Yep. So it's patient-owned. Yes. This is the one they have for the patient now. Mhm.
Not to make this more complicated, but if we are let's say we're not seeing them in clinic, we're talking to them on the phone, and we're able to access their continuous glucose monitor sensor data, CGM data remotely. So we use the bottom code for the telephone encounter.
Well, that's the question. When I'm in doubt, I like to say, let me get back into the office. I'll do my research and make sure when I reply,
Okay.
I'm giving you the right answer, because I'm not gonna run away with something like, yes, that's the one. So if you're accessing
Like
remotely, right, would that be appropriate? So I would follow up with that answer. Okay?
I think that's the standard. I don't think anybody understands.
Okay.
I don't think so, but that's,
And then one more question, the 95241, the patient owned.
941?
95249.
Yeah.
The patient owned, can you only bill once a month? If the patient comes every 2 weeks, is it?
I think there are billing parameters. So in terms of once a month, every 72 hours, whatever it is, its chances are it's once a month. So that I will not dispute unless I did some research on it and say, okay, Medicare is saying, sometimes Medicare is saying once every 3 months. So that information I don't have, but it's a possibility that it's once a month.
Yeah, I do have once a month.
Okay, so it's a possibility it's once a month. Okay. But what it's saying is the maximum of 72 hours data. If it's less than 72 hours data, what you also have is called a modifier for reduced service, and we won't get into that because I'll confuse the heck out of you even more.
Number of problems that need to be addressed in order to code amount to a certain level. I mean,
Not-
I was told that we need to at least address 3 problems in order to.
That's gonna be the next.
That's gonna be the next one when we're looking at evaluation and management, but I doubt it. You can have one
You can have a complex issue that
right,
requires,
Right.
look up different things, and that can be a non-complex.
look at cancer center. You can have one diagnosis and the complexity is that high. You know, multiple myeloma, kids, whatever it is. That workup itself to get you to a high level, but make sure you document your workup, your history of medical examination, whatever else that comes with it. And Michael is going to speak on that in terms of the elements for evaluation and management. But what I'm going to share with you is that a hospital billing for evaluation and management service is somewhat different because what we go by is what's called an acuity scale. So it's based on the resources used. So while the physician documentation should support the elements of evaluation and management services, hospital side, we are looking at what resources use. So that's forthcoming. And here's a question. Can evaluation and management service bill with your glucose monitoring, continuous glucose monitoring? And the answer is yes. And here's the explanation as to why it's yes. Then what modifier can you use or report on a claim to justify that it can be? I'm sure you've heard of 1525. Are you clear? Sure. So normally the patient comes in and the patient, okay, patient, you've seen a patient has uncontrolled diabetes and you've seen a patient and then the patient have some thyroid issues and you said, you know what, while I'm addressing your diabetes and what else that comes with it, the patient complained of some whatever lymph node, whatever the case is, and you said, I'm going to do this procedure as well. Can I do it? So this is totally from the glucose monitoring, but just to show you that you can have an office visit and a procedure, or you can look at the patient for glucose monitoring, the patient complain of something else, and you address it, which is totally different from the glucose monitoring. You're able to bill both. As long as there's documentation to support both, you're able to bill for it. Michael? Okay. Are we sure? I'm ready. Well, guys, it's a pleasure. Thank you.
So how do you add the modifier?
In Epic, you're supposed to see your your visit, and then there's just a small box on the right next to the evaluation and management service, and on the top it says mod. That is what is asking you for the modifier in your charge capture. Mike, is that right?
Different on the other side.
And chances are it look different on your side.
It would be nice to have a screenshot of it.
Or maybe the next time we're coming, maybe we can coordinate to have someone from Epic just sit in, and when you have these questions, they can show you or pull up a record for you and show you where you would auto modify it if need be.
I mean, if we pull up Epic, could you show us?
Let's see, I'm not sure because your view is, I'm charges, so I'm looking at charges.
Yeah.
But your view is
We don't
different.
have charges.
But your view is different from mine, but maybe, let's pull up Epic and see. Maybe somewhere we can navigate fast and I'll be like, okay, that's the modifier you should be looking for. Because most of the services, some of the services you do might require a modifier. Modifier 59 should be common if you're doing one procedure here and one procedure there, and normally it would consider bundle on the same site. Chances are you might need a 59 to make the distinction, just say, yeah, I did it. And although it's bundled, it was done on different sites. So you've never used a modifier before?
I don't think it's available. Because we go through the charges, we just, are saying, obviously we go through this,
Okay.
as well as the charge.
I can bring it, I'm sure.
I think so.
Next time. What I'll do is I'm gonna ask Larry. I gotta let him know I met with some guys, fellas, right? I'm sorry. And I stand corrected. And I'll let him know that if he can give us some screenshots of where you. So I'll ask the question and let's see. And if he can, I'll send it to you and then you can share it with the team. Okay? So I'll ask the question for you. So that's it.